and I'm with Roane State Community College, and I'm going to start answering the questions that have been submitted today. Question number 1 comes from Emily. How do we apply ALARA principles in daily radiographic practice, especially when balancing image quality and patient dose? So ALARA is as low as reasonably achievable, and it is the foundational principle guiding all radiation protection decisions in radiography. So in daily practice, it means we never expose a patient to more radiation than is diagnostically necessary. So some key applications to the ALARA principles is selecting the highest KDP that still provides acceptable image contrast, which reduces patient dose. Using a minimal number of projections needed for a complete diagnostic study as guided by your facilities with their protocols. Ensuring proper collimation to the area of interest, never larger than the image receptor. Repeating exposures only when the image is truly non-diagnostic, not for minor imperfections. And consulting technique charts if needed, if you're not sure what kind of exposure technique to use. So balancing image quality and dose is a clinical judgment, but ALARA just means that we want to obtain a quality image with the lowest amount of radiation possible. So the second question comes from Jacob. So how does beam restriction like collimation actually reduce patient dose and scatter radiation? Which is a great question. So collimation reduces patient dose through 2 direct mechanisms. It limits the volume of tissue irradiated and significantly reduces the production of scatter radiation. So what happens is when your X-ray beam is collimated down to a smaller field, you will have much less anatomy and tissue exposed to the radiation, which directly lowers the biological risks to the patient. You will have less Compton scatter produced because there are fewer interactions occurring in the tissue. And then therefore you also get your image quality improves because scatter radiation is a primary cause of reduced contrast in terms of adding that scatter to the film, which is unwanted fog on your image. So I like to tell my students, think of it like a road that you're driving down. The road is there, but you can't really see the radiograph underneath it because of all the fog is on top of it. So you can't see to get where you're going because the massive rain or fog is hiding the road. In this case, it would be your radiograph. So, and then of course, anytime you can reduce the amount of Compton scatter that is being produced, you're going to actually also indirectly decrease staff and personnel that may be, for example, in a fluoroscopy case out in the room. So think of it this way. For every lower amount of tissue that you remove from the primary beam, then you're going to end up getting less scatter, which will therefore reduce the patient's radiation dose and then also increase your quality of your radiographic image by increasing contrast. So this question, the next one comes from Sophia. So how do factors like SID and OID impact recorded detail and distortion on the radiograph? So your SID and OID both impact your geometric properties of the image. So for the SID, if you increase your SID, it's going to improve and make your recorded detail better by reducing the penumbra or the unsharpness in the image. That longer SID allows the beam to get more parallel, which reduces the divergence and the magnification. So you'll notice that sometimes we use standard SIDs on certain radiographs, like the chest X-ray, we use a 72-inch one. Increase in SID will, though, require an increase in mass, following the inverse square law. But overall, if you increase your SID, what happens is you end up having better detail and you're going to have less magnification. So your body part is going to appear more accurate, more true to the real size. OID will impact magnification as well. The more OID you have, the larger that the image will appear. Also, having OID is going to reduce your detail. So the best thing to do is have minimal OID. That's one of the reasons, for example, when we do a chest X-ray, like a chest PA, We prefer the PHS because the heart is an anterior structure or piece of anatomy. So by doing that PA projection, we are putting the heart on a chest x-ray as close to the image receptor as possible. Also, when there's unavoidable OID, the other thing that we tend to do is we move the SID back to help try to compensate for the loss of the detail and the magnification. So, for example, like a lateral C-spine or a lateral sternum, those would be times where sometimes you will notice that we justify moving the SID back to 72 inches. So in summary, what happens is if you want the best detail and the most accurate size, you're looking at a long SID and a minimal OID would be the best option there. So the next question comes from Michael. When using shielding like gonadal or lead aprons, how do we decide when it's appropriate versus when it might interfere with the exam? So it is worth noting that the professional bodies have recently updated their guidance concerning shielding. So I do want to point that out to you because some organizations have moved away from particularly abdominal shielding. So if you look at the ART's position, they will note, you can notice that healthcare institutions may adopt varying degrees of gonadal and fetal shielding recommendations. However, to address your question, if you are in the department that's going to use the protocol for the shielding, how you would make that decision is, will the use of the shielding obscure the area of diagnostic interest? Obviously, you would not want to use a shield in an area that's going to block what you are looking for. Also, if you were to use a shield in the area of an AEC chamber, the AEC chamber is not going to be able to do its job because it will pick up the shield as well. Okay, the next question comes from Ava. So how does increasing KVP versus mass impact patient dose? And which adjustment is generally safer from a radiation protection standpoint? So both KVP and mass do impact patient dose, but they do it kind of differently. So understanding the difference is critical. So when you increase your mass has a direct relationship with the amount of quantity of radiation or image receptor exposure. So the MA controls the current to the filament. So the more milliamperage or high current you have, the more electrons you will have available for X-ray production. S, or exposure time, is going to control how long you leave the tube on for the exposure. Both of those have that direct relationship. So if you go up in mass, the number of X-ray photons will also directly go up. However, changing your mass will not impact the energy of the X-ray beam. So we go up in mass for larger body parts, we go down in mass for the smaller anatomy. Now, if you start changing your KVP changes will ultimately change the energy and quality of the beam and also impact the quantity. So for every 15% increase in KVP, that approximately doubles the IR exposure on the image receptor. So if you were, for example, to use the 15% rule to maintain IR exposure, you would increase the KVP by 15% and cut your mass in half. Now, how does this impact the radiation protection? So if you were to increase your KVP, what happens is we will see a decrease in skin dose because the higher KVP is going to have higher energy X-rays in it, which will increase transmission and there will be less absorption. So if you had, from a radiation protection standpoint, high KVP, low mass techniques is generally preferred for dose reduction. So that way, as far as the patient is being exposed to radiation. However, you also need to go by the diagnostic requirements and the recommendations for each procedure. All right. The next question comes from Daniel. What are the most important responsibilities we have as technologists to minimize radiation exposure to ourselves and other staff members? So that is a really important question. So obviously, as radiographers, we are advocates for our profession. So we're going to make sure that our patients and everybody that we work with and ourselves is being protected from unavoidable exposure to radiation. So a couple of things that might be. So for example, for personal practices, you might make sure that you're never standing in the primary beam. Using the control booth and the lead aprons as much as possible, wear your assigned dosimeter in the correct position, collar level outside the lead apron. So that way you can get accurate thyroid eye measurements. Procedural are environmental responsibilities for the people around you. Make sure that if you're in a portable setting or in an OR or something, make sure that you clearly announce that you are taking an x-ray. So that way the people around you, the other healthcare staff are aware. Making sure that non-essential personnel are in the room during the exposure or family, depending on where the position is. And then also make sure that everyone positions themselves at a practical distance away from the portable machine during the x-ray exposure if it's a healthcare worker that cannot leave the area. Professional and ethical responsibilities, monitoring the dose records, making sure that you're staying underneath your occupational dose limits, which is 50 millisieverts a year, according to the NCRP guidelines, and making sure that all the cardinal principles of time, distance, and shielding are being applied. The next question comes from Olivia. Can you go over the inverse square law again and how it applies to protecting both the patient and the technologist during exposures? So the inverse square law states that radiation intensity is inversely proportional to the square of the distance from the source. Now, there is a mathematical formula, which is the original intensity divided by the new intensity, I1 divided by I2, which is equal to your new distance, or distance 2 squared, divided by your original distance, or D1 squared. So, but what does that mean? That means if you double the distance from the source, it's going to reduce that intensity down to 1/4. So the further back that you get away from the radiation source, you're going to see a pretty quick drop in exposure to radiation. So that's going to apply to radiation protection. As far as getting further away from the source, it's going to decrease the amount of radiation that is being received. All right. So let's see here. That comes back to the time, distance, shielding, the 3 cardinal principles. The inverse square law would be the basis that we use for the distance in terms of rad protection. The next question comes from Ethan. So I've heard about leakage radiation from the tube housing. How is that controlled, and what are the acceptable limits for safety? So leakage radiation refers to the x-rays that come out of the tube housing in directions other than the useful or primary beam. So x-ray production, when it occurs, it does occur isotropically, which means that x-rays are produced in 360 degrees at the anode. We're going to line the tube housing with lead to prevent leakage radiation. So those are the x-rays going in the directions that we don't care about. We want the ones going through the window or port towards the patient. So there is also a legal limit on how much is considered to be acceptable. And that limit is if you are standing at a distance 1 meter from the tube housing when operating at maximum technique settings, it is 1 milligray per hour. So, and if it exceeds that, obviously as a radiographer, we would need to make sure we get that checked. There is obviously quality control checks done on our equipment at least annually. And we're also checking to make sure that was the tube housing, was it mechanically something cracked, or did something happen that would prevent, make that leakage radiation above the limit. If anything looks weird with your tube housing, you always report it to your radiation safety officer or your manager, of course. So the question comes from Nia, the next question. In situations where we use AEC, how can improper positioning become a safety issue in terms of radiation dose? So AEC is a wonderful system in terms of keeping consistent exposures in terms of, making quality radiographs. However, it does depend on the radiographer selecting the correct chamber and making sure that they position the patient correctly. So, for example, if you are select the wrong chamber and you select maybe the center chamber when it was supposed to be a chest x-ray where you needed the two outer chambers, what would happen is the AEC system would pick up that big, dense, thick thoracic spine, so it would overexpose the patient. And you wouldn't be able to see the lungs that you were interested in because now they would be too dark. So, same thing, like maybe you're doing a lateral L spine and you don't have the vertebra completely over the center chamber. Maybe you have adipose tissue, the back. It would cut off too early, and then you would end up having a radiograph that was underexposed. So AEC is fabulous. However, in terms of positioning, we do have to make sure that we have it set correctly. So that way our first radiograph is taken and it is a success. AEC is also going to have a backup timer, which is important because maybe you accidentally selected the wall unit and you meant to be on the table. That's, at least in my experience, that's usually when I set off the backup timer at the hospital. So there is certain safety features also set in and included with the AEC chambers. All right, the next question comes from Liam. What steps should we take if a patient is pregnant or possibly pregnant, and how does that change our radiation protection approach? Okay, so obviously some of this will also be driven by your facility and what their protocol is. So always make sure that you follow the facility's protocol in that. But our initial assessment as rad techs, we always ask if there's any chance that they could be pregnant and then document the response according to facility protocol in the record. If the patient is possibly pregnant or confirmed to be pregnant, depending on the facility's protocol, consult with the referring physician, maybe the radiologist before proceeding. Sometimes studies could be deferred or replaced depending on what it is, the pathology they're looking for. The ordering physician and the radiologist must obviously be the ultimate decisions in this with the patient. If the exam is essential and cannot wait, we will proceed. However, according to facility protocol. However, there are things as rad techs that we could do. Make sure that you are collimating appropriately. Make sure that you're using the appropriate techniques and doing everything that you can to make sure that you are not going to have to repeat that radiograph. For example, because that would be a doubling dose within the patient, and the fetus would then get a double radiograph. Make sure that communication with the patient, making sure you explain what you're doing and what is going to happen. So that way they can lay still and not move near the radiograph. Those are all things that you could do to help reduce the dose. So, and that is it for the questions that was submitted today. Obviously, we do these different sessions on Tuesday and Thursday, so we will see you next Tuesday.